We'll discuss some biomechanics of tooth movement when applying orthodontic force, how this movement happens on the biological aspect, and what are the types of movements produced. Tooth movement is feasible due to the presence of the periodontal ligament that permits restricted movement within of the tooth socket, and it is the key of the ortho movement. When force is applied and changes happens in the jaw, it will compensate of this movement. There are three types of movement: the physiological normal movement, the pathological non-normal movement, and the orthodontic stimulated movement that is corrective. We will start with the physiological tooth movement, and it has three phases of tooth movement: bud movement before eruption, the pre-eruptive movement when it is erupting, and the post-eruptive movement. The first one, when the tooth germ movement is facilitated by the jaw growth, so its movement is connected with the jaw growth and until it reaches the position in the jaw for the eruption. The eruption movement is when the root has become 2/3 of its length, so it starts having a periodontal ligament traction, and it starts moving toward the crest of the bone. The eruption of the tooth is explained by the periodontal ligament traction theory. It says that the force exerted by the periodontal ligament fibroblast is transmitted to the collagen fiber bundles, and these forces will make bone remodeling. When the tooth becomes functional and there is an occlusal forces upon it, it will move mesially and occlusally on the opposite direction to compensate of the occlusal and the proximal wear throughout the person's life, and this continuous deposition of the cementum around the apex of the root of the teeth is sufficient to compensate for the occlusal wear. Now let's see what is the histological changes happen when we apply an orthodontic pressure or force. When we apply a force to the crown of the tooth, it is transmitted to the root and then to the periodontal ligament and to the alveolar bone. According to the direction of the force, there will be a resorption of alveolar bone in response to this stress. At the same time, there will be a deposition of the bone in the area of detention, so as to maintain the integrity of the tooth attachment. As a result, the bone remodeling of the socket of the tooth moves with the movement of the tooth through the alveolar bone. But if there was an exertion of excessive forces applied to the area, there will be no blood vessels in the area, and the periodontal ligament will be smashed, and there will be no nutritional supply that will reach it, and then the cells will be dead, and a cell-free area will be produced that is called the hyalinization area that does not have any osteoclast in it, so no resorption or movement will happen, and there will be a lag period of orthodontic movement. The resorption will be underneath this hyalinized area, And if forces are grossly excessive, resorption of the root surface may also occur, or non-vitality and ankylosis of the tooth is another consequences of extreme orthodontic forces. And the activity of the osteoclast will be more than the osteoblast, which means the resorption will be more than the deposition. By time, the periodontal ligament will be deprived of blood supply, and necrosis will happen to the ligament with massive underlying resorption, and will be a possible resorption of the tooth surface also. This heavy orthodontic forces will cause pain and loosening of the tooth in the socket. And if we removed the force and healing starts, there is a percentage of ankylosis of the tooth to the alveolar bone to happen. So the optimum force of orthodontic movement is 20 to 26 grams per centimeter cube on the root surface, which is equivalent to the capillary pulse pressure. So as we said, hyalinization is a type of tissue degeneration characterized by formation of a clear, homogeneous substance that is cellular free. We must take note that some amount of hyalinization of the periodontal ligament on the pressure side will always happen. We will always see it in the orthodontic movement, but its amount will vary depending on the force we apply. If it was in the normal or accepted range, we will get the appropriate movement that we want. So this hyalinization can be minimized by using mild continuous forces, and it will increase when we apply extreme forces. Now let's take a look about the phases of the tooth movement. That we will see that movement of the tooth has an diagram rate that starts with the initial phase, then there is a lag phase and the post-lag phase. What are these? Initial phase, when orthodontic therapy is begun, a rapid tooth movement occurs on a short distance, which then stops. And this initial movement is the same when we apply light or heavy movement, and this is due to the displacement of the periodontal ligament in space, and we will get 0.4 to 0.9 millimeter of tooth movement in a week's time. After that, there is a lag period in which there is a little or no tooth movement. It occurs due to the formation of the hyalinization tissue in the periodontal ligament, and as we said, it can be eliminated before tooth movement can progress further. This lag period will take between 2 to 3 weeks, and it can extend for longer periods. Then, after the hyalinized tissue is eliminated, tooth movement can now progress in a rapid rate, and osteoclasts are formed over a large surface area directly resorbing the bone surface facing the periodontal ligament. And this is considered the main histological phase of orthodontic movement. And there's a fluid dynamic theory that explains the movement of the tooth due to the ortho pressure, and it says that the tooth movement is a result of alteration in the fluid dynamics in the periodontal ligament. The periodontal ligament has some fluids like the blood vessels, the interstitial fluid, the cellular elements, and the viscous ground substance. Due to this nature of the periodontal ligament space, there is a hydrodynamic condition resembling a hydraulic mechanism is created. How it is created? When a force of shorter duration, as in mastication, is applied to the tooth, the fluid escapes through the tiny vascular channels. But after because this force is short and minimum, the fluid gets replenished by diffusion from the it gets capillaries and recirculation of the as soon as the force is removed, so it is returned to the periodontal ligament space. But when in normal mastication, but when longer forces are applied, in case of orthodontic tooth movement, these fluids gets squeezed out and moved toward the apex and the cervical margins. These fluids will make what is called pressure on the periodontal ligament, and its vessels will be compressed, and there will be like a concentration of the blood in this area, and it will form like a balloon of blood that is called aneurysm. Formation of aneurysm causes the blood gases to escape into the interstitial fluid, creating a favorable local environment for resorption. Another theory that explains the bone remodeling is the piezoelectric theory, and it suggests that when orthodontic force is applied to the teeth, it causes deformation of the alveolar bone, and the alveolar bone is composed of hydroxy apatite crystals that exhibit piezoelectricity, which is a phenomenon in which deformation of the crystal produces a flow of current as a result of displacement of the electrons from one part of the crystal lattice to the other. And other compositions have this effect, like the collagen fibers and the polysaccharides that are present on the ground substance that produce this electric current. This force will make the bone deformed, and in the concave area, it will be negatively charged, which will attract the bone deposition cells, which are the osteoblasts, and in the convexity there it will be positive charged, and it will attract the bone resorption cells, which are the osteoclasts. We have understood now the theories of the bone deposition and resorption and how it happens. We have seen the phases of the tooth movement and the types of movements, whether they are physiological, pathological, or orthodontic. Now let's see how we can use these concepts to get the appropriate movement that we want. The center of resistance is a point on the tooth that can be single, or it can be multiple for units of the teeth in the complete arch or the jaw, that when force is applied to it, a bodily movement happen to the body, which means that it will all of its parts will move at the same amount in the same direction. However, orthodontist is seldom possible to apply force at the center of resistance because it is located on the root, as the brackets can only be placed on the crown of the tooth. This is the center of resistance in multi-rooted tooth and in single tooth. So if this force is, when applied to the body, is not at the center of resistance, the movement that we will get is called rotation. The tendency of a body to be rotated is called the moment. This is the moment, but the couple is when two parallel forces of equal magnitude acting in opposite directions to get a pure rotation of the body about the center of resistance. This is a force couple when two parallel forces of equal magnitude acting in opposite direction to get pure rotation of the tooth. In general, the orthodontic movement is a combination between displacement and rotation. We can see pure translation clinically in these three types of movements: the intrusion of the tooth and the extrusion and the bodily movement in the mesiodistal or the labiolingual direction. And we get pure rotation in also three types of movements. When the force is applied along the axis of the tooth, we will get rotation. And if it is applied in the facial-lingual axis, it is called tipping, where the crown movement is in the opposite direction of the root. Around the mesiodistal axis is called torque. What is torque? Torque is a movement of root without the movement of the crown. So the torque is achieved by applying a force coupled to the crown of the tooth, at the same time restricting the crown movement in the opposite direction. And the center of rotation is at the incisal edge or the bracket. Thus, the type of force that we will apply regarding the duration and the magnitude. If it is a continuous force, we are applying light and continuous force, which will give us the most efficient of tooth movement, that we will get the appropriate frontal resorption, and it is achieved by flexible wires and light elastics that will make this movement. Another movement is the intermittent force, is that after applying an amount of force, it will decays to zero before the next appointment, like when using removable appliances with an expansion screw. So we perform high magnitude and cause a resorption. Then before applying another type of magnitude force, the force becomes zero. So we give a tooth time for a resumption of blood supply in the periodontal ligament tissue. Another type of movement of force is the interrupted force. When the force is interrupted by an appliance, when it is inactive, which means that when it is removed from the oral cavity, or if it was external, as the headgears, which means that we apply a high magnitude of force for an interval of time during the day. Then we remove it to prevent any excessive force consequences that will give us an opposite results. But this interrupted phases of forced application will bring up our skeletal changes that we need. So we can come to a conclusion that not applying a continuous force for a continuous time will give us the best results. We must apply the appropriate force with its appropriate magnitude for the appropriate time. because the movement of the teeth is complex and it relies on biological changes occurring on the periodontal tissues and the cellular level.